Hi, my name is Victoria Batchelor, and on behalf of SBK Healthcare, I'm delighted to welcome you to the recording of this webinar on delivering a connected virtual ward point of care testing service webinar. This webinar will give you the opportunity to hear the lessons learned from delivering a connected virtual ward service, how to navigate the challenges, and establish a multi-organisational model. The webinar has been designed for NHS professionals who are dedicated to driving forward their point of care testing services. And you'll hear the first-hand experience of your leader, Roanna George, Consultant Clinical Biochemist from University Hospitals Plymouth NHS Trust. Please make sure you check out our website for our other webinar content. We also run in-person conferences, such as our Point of Care Testing National Networking Forum conference that's coming up soon, and other online training, which all the details can be found on our website at www.sbk-healthcare.co.uk. Thank you, and I hope you find this webinar informative and enjoyable.
Welcome everybody. My name is Roanna George. I am a Consultant Clinical Biochemist and Clinical Lead for Point of Care Testing at University Hospitals Plymouth NHS Trust. And I'm here to talk to you today about our experience of delivering a connected virtual ward service. Now, I will caveat this at the start that we are not quite fully connected yet. So we have been on quite a long journey to get to where we have now. So we haven't quite got our results in the electronic patient record as yet. But hopefully we can share some useful experiences with you of what we've done over the last year to move this project forward. So as an overview, I'm going to be talking about establishing a multi-organisational model to enable point of care on virtual wards, because multidisciplinary team working is really important in implementing point of care testing in this type of scenario. Delivering a connected service to aid clinical decision making to avoid unnecessary hospital admissions and improve outcomes. So this is how we are trying to get results into the electronic patient record for easy flow of being able to manage these patients. And then evaluating the service. So we went live a couple of weeks ago, so we haven't got full outcome data as yet. But I'm going to talk to a little bit about how you need to try and demonstrate the value and impact of virtual wards and the types of metrics that you would consider collecting. Okay, so what are virtual wards? So virtual wards allow hospital level care to be delivered in a patient home, and this is to prevent hospital admission or facilitate earlier discharge. So the prevention to hospital admission, this is known as step up care. So these are patients that are in places like emergency department and may need admission, and rather than admitting them to the hospital, they will be able to admit those patients to a virtual ward, or to facilitate earlier discharge from people that are already in hospital, which is known as step-down care. Delivery of this model of care has accelerated because of the pandemic, because accessing healthcare in centralised settings was very challenging. The virtual ward hospital at home model has been around for quite a while, but the pandemic has really accelerated its use. And they're now high on the national agenda because hospitals are struggling to cope with capacity, as we all know from the ageing population and the demand for beds in the hospital setting. So we've now got rapid deployment of virtual wards in different specialties across the country, and the services are all very different from each other. So the model of service delivery in every hospital and all the types of acute wards and who looks after those, whether it's acute or community services, will differ depending on where you are in the country. So be mindful of that throughout the talk. So there are lots of benefits of virtual wards, and this is taken from the GIRF Virtual Ward Programme guidance, so you can read that at your leisure. But essentially it increases patient choice. Generally there's better patient outcomes because they're able to stay in their home environment. It also means that they're more mobile, so that can reduce some of the consequences of being in hospital, from having reduced mobility from being in a hospital bed. They're less likely to acquire infection because they're at home and not with lots of other people on a ward. It frees up physical space. So there's lots and lots of benefits of having virtual wards in use. So in University Hospitals Plymouth NHS Trust, the acute virtual wards went live in December 2022, and the community virtual wards have followed in 2024. Point of care implementation was a recommendation from the NHSE GIRFT peer review that was undertaken on the virtual ward service. And so approximately this time last year, we applied for medtech funding, which was a national funding stream to enable us to procure devices to use in the virtual ward setting. So this was the medtech funding bid. So the aim was that it addressed a national priority in line with the categories on the next slide, which is given there. So ours was under priority 1, which was virtual wards in clinics, and it needed to accelerate the adoption of technology that addresses a local unmet need. So this was point of care testing to enable quicker clinical decision making on the virtual wards. It needed to have tangible benefits for patient and or improve staff productivity. So the point of care testing would be beneficial for the patients because it means that they don't have to wait for their results. And it particularly improves staff productivity because what was happening currently was that if there was an urgent blood required or they felt that someone was deteriorating, that patient was either admitted to hospital or the staff member would have to physically take the bloods to the hospital themselves, which takes staff time away from visiting other patients because they're transporting bloods to and from the hospital. So our model in Plymouth, the aim then, so we have virtual ward services which are run out of Plymouth, Derriford Hospital, Acute Trust. And we also have, we've decided to also use the point of care testing for urgent community response cases, because these are managed by the same team. So the visits are done by the same team in Plymouth. So in terms of urgent community response, these are patients that need someone to come and visit them within 2 hours. And these are patients that might otherwise have been treated by ambulance services or other services or attended ED. So that's supposed to try and avoid those admissions to those services. So the point of care, so there are 2 services, Plymouth and South Devon, South Ham, sorry. And so that covers a significant geography around the South Devon area. So the devices are housed in a community hub. And this hub, there are 2 sets of devices used for virtual ward services and 3 devices set aside for urgent community response services in Plymouth. Then there's 3 devices for South Ham's urgent community response services, and 2 devices are kept as backup in case there's a case that is required, that there's a device that is required to go to a specific case that wasn't pre-agreed or we didn't realise until those visits were made. So the devices are kept in the community hub, taken to the patient's home where testing is completed. What we then want is for results to be sent into ICM, which is into the Trust Integration Engine, which will then transfer results to ICM, which is our electronic patient record. Here, they would be able to be viewed by the clinician who is reviewing those results, and then the clinician would decide what the course of action was and feed that back to the person in the patient's home. So this is what we're aiming for and what we're quite close to achieving, but we haven't quite got those results into the patient record as yet. But this is the model that we're trying to follow, and I'll explain a little bit about where we are shortly. So one of the keys to success of implementation of point of care was establishing an appropriate working group. So it's really important that we have stakeholders from each of the areas to ensure that people with the right expertise are involved to be able to deliver this service. So you've got clinicians who are, in our case, it's acute GPs. So the acute GP service oversee both urgent community response referrals and virtual ward referrals. So they are key in making that clinical decision. And that's one really important aspect of implementing point of care testing on a virtual ward, is that you need a clinical decision maker available, because often the person that's going out to do the test won't be the person necessarily that is making the clinical judgment. So it's really important that that clinician is available, otherwise point of care testing it loses some of its benefit. The point of care team were really instrumental in setting this up, and I'll go through how the point of care team have supported the rollout. The virtual ward teams and the urgent community response teams, they are the people that will be running the testing. For us, HLP is the Healthy Lives Partnership, and they sit between the acute and community services to bring those services together, and that's where our project manager sat. Then we had pharmacy, SWAST and IT also involved. So SWAST are involved because some of the urgent community response calls could have gone to the paramedics. The paramedics will then refer to the urgent community response team because they're aware then that they've got point of care testing. And pharmacy are involved in case prescribing is needed and for advice on those types of cases. And then IT are integral for getting the results into the patient record, but also for security measures to allow appropriate connectivity in the community. So we set up stakeholder working groups and we met regularly as the project progressed, and then meetings were stepped up and stepped down as needed depending on the workflow at the time. Other important stakeholders to consider, I've called them implementation stakeholders because they're people that aren't necessarily on the working group but need to be informed of the project so that everything is put in place appropriately for your trust or governance structure. So procurement, it's important here to register the kit so that they're aware that the kit exists, and if there are things like product alert notices or any issues with the kit, procurement have an awareness and there's a track basically that you've got that kit in your trust. And it also ensures that it's in future budget forecasts because the kit, we've bought the kit using external funding, but if that kit is to break down or needs replacement, then the trust need to be aware that that might be needed in the future. So they will forecast that and sign that off as acceptable to bring in. Cybersecurity and networks teams are also really important, and this is to ensure safe connectivity. This is particularly important in community connectivity because you need additional layers of security because you're outside of the acute trust. So you would be outside of the acute trust IT network, which means, as we all know from things like working from home, you need additional levels of security to be able to dial into the trust network. Your trust and pathology IT are important to configure and map test to patient records. Often one of the barriers in point of implementation of point of care testing is the fact that the results aren't in the electronic patient record. This will differ, and there are some trusts that do have results in the patient record, but not all trusts do, and particularly with newer devices, handheld devices that are coming on the market, they might not already be configured. Governance teams are also important to ensure that due diligence has taken place and that they're happy with the processes and procedures that have been implemented as part of the project. So the implementation steps. So we started the project plan by completing a new service request form, which is part of a service evaluation framework that we're currently launching in the Southwest. So I'll explain a bit of that shortly. This outlines the tests that are needed. So this is sodium, potassium, creatinine, lactate, hemoglobin, and CRP. Then we went through, and I'll go through these steps in the next slides, the verification of the devices, the training of users, the creating of the documentation and the processes, the connectivity and the data collection. So the service evaluation framework has been introduced to facilitate rollout of point of care testing, particularly in services that aren't clear on the governance arrangements required for point of care testing. So what we want when any point of care test is introduced is for the user wanting to deploy that device to talk to their local point of care team. However, there's different resourcing in point of care teams all through the country. So some point of care teams won't have the capacity to undertake governance of new devices that are being brought to market or might be needed to facilitate patient care, such as in these situations. So this form is an outline of everything, all the governance elements that need to be undertaken to make sure that point of care is undertaken to fulfill an unmet need, because often it's thought that a quicker turnaround time is bound to improve patient care or patient outcome, but it doesn't always. So for example, as I said earlier, if there's no clinical decision maker available, it might be that the increased turnaround time doesn't have a significant benefit. It ensures that there's pathology engagement at the start of the project so that they're aware. And the idea is that there's a joint conversation between the pathology team and the user as to who's going to take governance and who has capacity to undertake. the appropriate governance items. And it makes sure that all appropriate governance is in place, all aspects of implementing a point of care service have been considered, and it outlines outcome data being gathered to prove effectiveness, because often, again, tests are introduced, but the effectiveness of those tests aren't always gathered afterwards. The data isn't always gathered afterwards. So this is particularly important in trials such as the one that we're undertaking on virtual wards now, because you need the outcome data to prove the benefit to support business cases moving forward to keep those services in place. And the aim of the framework is to give practical guidance on the principles in the IBMS ACB, which is now the Association for Laboratory Medicine, ALM, the RC Path, Royal College of Pathologists Point of Care National Strategy that was published last year. So that's a good source of information for implementation of point of care testing. So this is what the framework looks like. It's split into 4 main sections. Evaluation of feasibility, which is the first step that we filled out. We filled out that form in conjunction with the virtual ward teams for this project. Then there's also information on implementation, the steps that you need to take to implement point of care testing, outcome data collection, and business case, as I've just mentioned. So just briefly, evaluation and feasibility, the first part of the form is completed by the user. So we got together with the virtual ward and urgent community response teams to identify what tests we needed, who was going to be tested and when, and to work out the metrics that we were going to collect to prove the benefit. Part B is then completed by the point of care team if they have the resource to do so. And this is where you look at what devices are available, what the performance is, and if there is appropriate technology to support the test in that required setting. It also looks at the connectivity and confirms device capability. Part C then is a joint discussion between the point of care team and the user. So virtual wards and urgent community response in this case, deciding whether the test does meet the needs that were required. So for example, part A, it would have been on all virtual wards, or it would have potentially been used on all patients on virtual wards that needed testing, or in an urgent community response setting. However, the test performance in some cases isn't good enough for monitoring. So the decision was made that the test would only be used where an immediate clinical decision is required, and it wouldn't be used for monitoring because the results cannot be used interchangeably with the laboratory, because the results differ based on the technology rather than the fact that there's necessarily a change in the clinical condition. We then assign the governance and quality responsibilities, and I'll go through how we've defined those later in the presentation. And then the last section outlines all of the risks and mitigations, because there inherently is risk with point of care testing, but this section just ensures that those risks are mitigated, and if the risk outweighs the benefit, then you wouldn't proceed, but if the risk outweighs the harm, then you would continue. So this is our project plan. So it's been a long project. So we verified the devices over the summer to make sure that the performance was appropriate for deployment on virtual wards. We agreed on the outcome metrics that we were going to collect. We then spent the autumn drafting our SOPs, so working out what our processes were going to be. We have had a long project working on getting the results into our electronic patient record, and that's still ongoing at the moment. We undertook device verification checks, so that's checking that each of the individual devices themselves are suitable and there's no issues. We undertook the staff training, and now we're in the process of data collection because we went live the week before last. Comms need to be drafted, but we're going to do that once the testing is embedded. So they will be due to come in the next couple of weeks. So device selection. So there are different handheld devices, and the appropriate device for your organisation will depend on multiple different things. So ease of use of the device, how you store the reagents, whether those devices are already in use in your trust or not, whether you can connect the results or not, what the test repertoire is. So you could have some devices that have multiple cartridges that cover your test repertoire and have a wider test repertoire, or you could have devices that you only need to use one cartridge for your entire test repertoire. So there's lots of items that will go into picking the devices that you will use. The performance of the device also is important. So how do the results of the device compared to your laboratory results. So we'll talk a little bit about verification data in a second, but that's what you would do. You would get hold of verification data to see what the comparison is like. We ended up with Lumira devices for CRP and epochs for blood gases. One of the main reasons was that we already had epochs in use in our trust, so it made sense to continue with using the same devices. But as I said, there's lots of different aspects that you would need to consider for suitability in your own settings. So it's important to obtain verification data to understand the differences between the point of care kit and your laboratory results, and this is to prevent misinterpretation and to be able to interpret those results appropriately. It's really important to use laboratory as well as manufacturer data, because the manufacturer data is often collated in very controlled conditions, so it is sometimes better than the data that you see when you actually use it within the laboratory. And the laboratory itself, the main lab will have different kit depending on what trust you're in, so there will be differences in performance between laboratories across the UK, let alone between your handheld analyzers or your point of care devices that you're putting into use. So it's recommended that you look at both types of data. Your local laboratory doesn't necessarily need to do the verification, because it might well be that you can obtain the verification data from other labs that have already undertaken that process. So always check what analyzers are in use in your local lab first. So data should cover the measuring range and clinical decision limits, because you can have verifications done, but they only maybe cover results in the normal range. So just be careful to double check what that verification covers. Does it cover high results, low results, and results near to the clinical decision limits? Ideally, it needs to be the same sample type. So point of care verification can be quite difficult, because often you could use capillary samples, which aren't always verified. So just be careful if you're looking at venous capillary data and what sample type the verification has been undertaken with. And ideally, this data should cover imprecision and bias. So imprecision is, am I getting the same result every time? Bias is, am I getting the right result? Is it accurate? Accuracy, if you've got a slight bias and it's consistent and your device is very imprecise, then you can account for that bias when you undertake your interpretation. If it's got poor imprecision, then it can be harder then to make a clinical decision based on those results. Transporting the devices needs to also be considered. So we've ended up purchasing a carry case, which is flat, and you can wipe it down, and it's very easy to use, and it fits all the devices in. Just be careful that things like chargers, if you're putting things in the same bag, the screens could be cracked, so just be careful with things like that. So we carry our chargers in a separate bag to prevent damaging any screens. We've got temperature probes that we put into the case to be able to monitor the temperature. So training, it's important to have a robust training programme. The way we do it at University Hospitals Plymouth NHS Trust is that we demonstrate the use of the devices following a defined syllabus. The trainee then runs a test themselves, and then they complete an online quiz. And that online quiz makes sure that they've got the appropriate knowledge that they need, and brings out key elements of learning that they need to be able to undertake the testing. There are different models of delivery of training. We use the point of care team in this case to deliver all training. What we normally do is we use the link trainer model. So the manufacturer or the point of care team will train a link trainer in the defined area, and then the link trainer will train everybody else. But because this was a completely new service with people with no experience at all of point of care testing, we decided that the point of care team would deliver all of the training in this instance. And then we'll work with the virtual wards and urgent community response teams over the coming months. And then next year, it might be decided that we do move to the link training model. But for now, that's how we're delivering our training. And it's important to ensure that training records are stored appropriately for governance requirements, so that you know that people are trained to use the kit. Quality assurance. So we run internal quality control, also known as IQC. And this is run by the virtual ward and urgent community response teams. We've decided to run it weekly. With point of care testing, you need to think about the workload, the significance of the results, and the ease of the use of the device when you decide how often or frequently you're going to run your IQC, because it's not like the laboratory where we would run IQC every day or with every batch of samples. So also you need to consider whether it's a particular reagent, a whole reagent pack that's being used more than once, or in these cases, they're single-use cartridges. So because it's a single-use cartridge, really you don't need to IQC it all the time frequently, because you're IQCing that individual cartridge as one at a time. So we're currently doing weekly, and we're doing 2 levels weekly, but we're going to monitor the performance over the next few weeks, and it might be that we do one level on alternate weeks, because it is also quite time consuming to IQC all of the analyzers at once. The external quite inexpensive, that's the other thing, is the cost, because the cost per test is more expensive than the laboratory. So external quality assurance is also run, and this is monthly, and this is run by the point of care team, and the results are reviewed, and any performance issues will then be fed back and discussed with the virtual ward service. So other governance activities that have been undertaken. So the point of care team maintain the asset register of the devices. They've created the stock take sheets and ordering of the reagents. They will interpret the IQC and EQA and audit the service. That will be taken once the service is properly embedded. An audit will happen to see if all the governance elements are being adhered to. The virtual ward and urgent community response teams are then responsible for doing the stock take, storing the reagents appropriately, running the IQC, and ensuring that the results are recorded in the record appropriately. And the service SOP has been written jointly by both services, both teams. So connectivity. So this is just a basic overview of connectivity now. So a point of care test done on a device will flow into a middleware. So that will either be the company's own middleware for that specific device, or it could be an overarching middleware. So point of care services often have one middleware that all the devices will flow into, and that all the operators are managed, the IQC is managed, all the data is managed through that one middleware system, and that will then flow into the main electronic patient records. However, sometimes you end up that the middleware isn't capable of connecting with some of the devices, so you could end up with multiple types of middleware in place. So you might not all be connecting through one middleware. If you've got any questions on that, pop that in the chat. So then once they've gone through the middleware, the results will go to the Trust integration engine, and from there they will be sent to ICM, which is our hospital electronic patient record, but we also need them to be sent into the community electronic patient record, which in our case is ICE. So at the moment we have blood gas results going through our middleware into the hospital IT system, but we don't have any results going into our community IT system. So that our aim of this project, then we set up a connectivity working group to get the results into both systems. So there is an added complexity, however, in the community, because in the trust, when you've got point of care devices located in your acute trust, then they are all hosted on the trust network. So that's all got the layers of security that you need to allow that results transfer. However, once you go into the community, a little bit like I said earlier, with your laptops when you're working from home, you need a VPN or some form of security layer to allow you to dial into your trust host network. So it's really important when you want to connect devices that you know whether they can be connected and whether the security is suitable for your individual trusts. So for the Lumira, we've ended up, because of the security, we wanted to feed our Lumira devices through our middleware into Aegis POCT. So Aegis POCT is our current middleware. Everyone will have different ones across the country. But we weren't able to do that for security reasons. So Lumira have an app which has all of the required security settings on it. So that allows us to then use Wi-Fi signal. Once the test is completed, the results will upload onto the app. They'll be sent via a cloud, and then the HL7 messages will be received by the Trust integration engine and then be displayed in the software. So once this is all set up, so we're in the very final stages of getting this set up. The idea is that this also gives you positive patient ID, because the Trust integration engine in the cloud can double cross-check your patient record to make sure that the hospital number that you've put in is the patient that you think it is. But at the moment, obviously, one disadvantage of us not having that at the moment is that we don't have positive patient ID directly at the home. So the EPOC is a little bit more difficult because the software on the EPOC is an older version. So there are certain software versions you'd have to check with the company for whatever device that you're connecting, and also your Trust IT. But there are different versions of software incorporated in different devices. So in the case of the EPOC, we've had to put in an additional security layer to enable us to then transfer our results into the middleware to then be received by the Trust integration engine and then go into our electronic patient records, as mentioned. So this is what we're testing at the moment. So we have to use the mobile phone as a source of internet of hotspot for the hotspot signal. So that will give the connection. A laptop, it'll then connect to a laptop with a VPN on it, and then that VPN is similar to your working from home laptops. That will then be allowed to go into the hospital system via that secure VPN. So you'll do your test and then the results will transfer, as we've already discussed. The reason you need to tether the mobile phone is that the laptop isn't capable of sending and receiving a hotspot and a wireless connection at the same time. So it has to wirelessly connect with the EPOC, and then the phone is used to be able to hotspot the mobile phone signal. So then the next conundrum of connectivity for point of care results is making sure that your point of care results are separate from your laboratory results. As we've mentioned, you might not have 100% comparable results. Creatinine is a good example. So if your results are stored in the same place as your laboratory results, then you could end up using results from different devices to trend the patient, to trend the changes in the results on that specific patient, which might not be appropriate because of the differing device performance. So on the left-hand side, this is what our electronic patient record looks like. And as you can see, you've got the results split by imaging, endoscopy, cardiology, and then the laboratory. And point of care testing is its own section at the bottom of the laboratory list. So that then means that your results from the chemistry laboratory are not in the same place. So that defines that they're point of care. We've already got our benchtop blood gas analyzers going into our hospital system, but the blood gases on the handheld EPOC devices, or the results from that device, not necessarily the gases themselves, but the glucose, sodium, potassium, etc., might also be slightly different from the benchtop analyzers. So we've decided that what we're going to do is split the results out by device. So similar with CRP, we've got more than one point of care device that does a CRP test. So that's the route that we've gone down, is to split out the coding so that they come across assigned to the device that they've come from. So again, we can't interchange trending of results. The plan is that we'll then review this mapping over the next, once it's live, so that we can see how the clinicians respond to it and if there's any feedback and any changes that we would need to make. So there's a number of IT challenges. So the first one was NHS number versus hospital number. So we wanted to move to using NHS number because that's the direction of travel for the future, is that we want to be moving to NHS number. And with community cases, people might not have had a visit to hospital, so they might not have a hospital number generated. So, but they're likely to have an NHS number. There will, of course, be a small subset of patients that don't have it either, because they're on holiday or they haven't registered, they haven't got an NHS number for whatever reason, but that should be such a small subset of the population that we decided we were going to go with NHS number. However, what we found is that some devices are unable to scan 2D barcodes which contain the NHS number, so they can only scan a 1D barcode, which is then your hospital number. The Trust integration engine can use either NHS number or hospital number, but our middleware can't use one or the other. It can't use both, it can only use one or the other. And because some of the devices that we have already connected can only scan the hospital number, it meant that we've had to stick with using the hospital number for now. So we would like to move in the future, but for now we have to stick with hospital number only. And the virtual wards and the UCNS teams were happy with that, because they did say that they did a quick trawl, and most of the patients that they visited already had a hospital number. For virtual wards they will be, because they will have been admitted, and there were very few patients from the urgent community response service that didn't have a hospital number. Mapping test codes with the same name can be tricky as well. So if you are sending a test such as CRP, that test might be coming from the laboratory, or it might be coming from multiple different point of care devices. And if you want them split out into separate entities, as we have done on our system, then you can't use the same name, because it will recognise the name and just pop it in, say, the chemistry section on ICM. So we've had to find ways to define what device it's coming from, so that we're able to split out the devices on our electronic patient record. This will all be dependent on your capability of your IT systems in your trust, just to be aware. So we were lucky in the way that we wanted to go through one overarching middleware. We ended up not being able to do that because of different middleware capabilities, but that's actually been beneficial, because you can see, you can pick out in the coding which device or which middleware the result has come from. So because we've got CRP, for example, on more than one different types of middleware, that's what we've used as the trigger to pop it into the correct box or the correct field in our patient record. Testing. When you're testing connectivity, make sure that you know how you want the configuration to be in the electronic patient record up front. So it's really important to make sure you know exactly what you want it to look like, what you want to go across. Do you want what units, what reference ranges? Because what's ended up happening in some of our testing is the test code itself has gone across and not the test name. So this is into our community system now. So you need to make it really clear what you're testing, so that you pick that up at a really early phase if things don't look as they should. Community connectivity, make sure that you involved your IT teams early to ensure that the solution fits with your local security needs. So we've talked about the extra complexities of the connectivity in the community and the extra layers of security that are needed, and so they'll be different for different devices. Middleware capability issues we've talked about. So there are drivers often that your middleware will need to have to enable a connection to multiple devices, and so in our specific middleware, the driver capability wasn't good enough. And the driver capability has things like, can you control your operators? Can you manage your devices via that middleware? And so you just need to check what your middleware can do before you sign up for specific devices if you want to get them connected. And then you can need to explore the options of connecting them before you start. Cost is important. So don't forget, when you're procuring devices, if you do want them connected, you need to budget for the cost of the drivers and the licenses, either one-off costs or the cost moving forward, and that will differ again depending on your types of devices that you're using. And reference ranges are a challenge, because different device performance might mean that you could misinterpret something according to the reference range. And also the transfer capability. So as it stands at the moment, some point of care devices are not capable of either transferring reference ranges, or they're not capable of transferring age-related or male or female reference ranges. So you need to check your device capability as to what it can send to the electronic patient record, because otherwise you could end up with incorrect reference ranges against which results are being interpreted. So the last little section then is on demonstrating value. So as I've said, we've created data collection spreadsheets for our virtual ward teams and our ARPs. So there are urgent community response practitioners. They're known as acute response practitioners. They fill out the front end of the spreadsheet. And this is about the patient details, where they are, where they've come from, when the point of care testing was done. And if the point of care testing wasn't done, why wasn't it done? Did the patient decline? If so, what was the reason? We've also recorded device failures. So another important aspect of point of care is the robustness of the test kit itself. And there's often a certain rate of failure associated with the devices. So what we wanted to collect was information on how often the device failed and why, so that we can use that for either retraining or to work out if we're going to have a high failure rate. So that can be budgeted for. We haven't seen too many failures at the moment, which is good news. Also, then, how long did it take from the blood collection to interpretation? This is back to the clinical decision maker, because if the clinical decision maker isn't available, then the point of care test won't have the desired effect of increasing the speed of clinical decision making. What was the outcome? Was admission avoided? How many miles did you save? So would that have been a sample that you would have urgently dropped off to the hospital? In which case, what distance would you have travelled? When were you discharged? Where to? And where were the onward referrals? And then our virtual ward team are collecting the length of stay on the virtual ward and on the virtual ward, so that we can see if there are any differences pre and post point of care testing. Then there's a next section for the clinicians, and this is essentially looking at what instigated the testing, what test did they need, were the results normal or abnormal, and did they correlate with what was expected? Did they lead to a medication change, and what would the action have been pre and post point of care? So if you had point of care, what did you do because you had it? If you hadn't have had it, what would your action have been? So that might be admission, for example, whereas they might say, oh, I had the test result that reassured me that the patient was okay. So we didn't have to admit that patient. We've also done a patient survey, and we're going to get feedback from the clinicians on their experience. So the patient survey is being sent or being given to anyone who's had point of care testing. This isn't the full survey, it's just a subsection. One thing about surveys to remember is it's important for them to be in plain English where possible, so that they can be understood. There are reading scores on Word that you can use to try and make sure the language is as simple as possible. We've also got a free text section, because these strongly agree, neither boxes are okay, but they only give you quantitative data. They don't give you reasons behind why something was good or not so good. So we've got a free text area, which is probably going to be the most useful for them to fill in a bit more information on their experience. And in terms of clinician experience, we'll do some interviews with the clinicians to find out how they found it and whether it was beneficial. So in summary, a multidisciplinary team is essential to enable delivery of point of care testing on virtual ward services. It's really important to invite all stakeholders to regular meetings for shared decision making, and strong leadership is required. It's really hard sometimes to get clinician time, but they're also really able to make sure that they're involved in the decisions from the beginning. And we couldn't have done it without our multidisciplinary team, because everybody has different areas of expertise. I'm not an IT expert, for example. The people on the virtual ward aren't point of care experts, so we were all able to share our experience to put the appropriate processes in place. Successful implementation depends on the patient pathways and the service configuration in each trust. So some of what I've gone through today will be specific to our trust, so just be aware of that. Connectivity is challenging and needs to be initiated early in the project. So we've been working for quite a few months now with our IT teams to try and get those results into the electronic patient record, but we are doing that for a range of our point of care results, and not just the ones for virtual wards. So it depends how much you are connecting as to how big the project will be, and you need to be clear on quantifying the benefit, which is often challenging. So what I always say with outcome metrics is try and collect metrics on what you want the outcome to be. So changing clinical decision or admission avoidance, or make it clear what you want to quantify, because just having an increased turnaround time isn't necessarily, you need the outcome after that that improved turnaround time and what that means. And at the moment, we're relying on manual data collection. So it's people filling in spreadsheets, and that will determine the quality of the data. So it's really important that everybody understands exactly what each box on that spreadsheet means to enable you to get robust data. And we've just started the data collection now. So we're in the process of going backwards and forwards to refine the spreadsheet to make sure that we're getting the data that we need. So just quickly to acknowledge the point of care team working group who have been instrumental in getting this delivered, the point of care team who have done loads of work behind the scenes, done all the training, created a lot of the documentation, all the governance elements that we've talked about in previous slides. And Charlotte and Neil for leading the project. They've been brilliant with project managing and getting to know the right people and talking to the right people in the trust. And Neil's produced all the diagrams. So big credit to him for doing that. So any questions?
Hello, hi Roanna, thank you so much for that. So we're now going to go into the Q&A part of the webinar. So if anyone's got any questions or things that they would like to speak about, if you pop over to the Q&A box and start putting in your questions there. We do have some all ready for you. So from Andy Turner, they say, can you share examples of benefits and patient outcomes which are being measured?
Yeah, so we have got the admission avoidance, so where the patients end up going. So are they transferred to hospital? Have we avoided an admission? So we're collecting those metrics. We're also looking at the length of stay on the virtual ward. We want the length of stay on the virtual ward to increase because it means that you're not using up a hospital bed. So you've also got to be careful with what metrics you're collecting versus national metrics and stipulations. So the national metrics will often say that they're looking at hospital length of stay. So be really careful with what you're collecting there. Then in terms of decision making, what we've done is said, what would you have done before and what would you have done after? And there's a drop down menu, and it's things like given antibiotics versus held the prescription, admitted the patient, sent them for bloods versus kept them at home, or it could be that they're the same, they haven't actually changed their decision. So I can probably share the spreadsheet if that helps, and then that will give you the drop downs that we've got and we've put into our metrics collections.
Fantastic. And another question is, how are clinicians gearing up to support clinical decision making on point of care testing results for patients outside a hospital setting? And in addition, is additional capacity in place given clinical teams are already stretched caring for patients in the hospital?
Yeah, so the already stretched bit is a big one. So that's one of the big problems with virtual ward delivery, is that there are additional beds, but you need additional staff to be able to deal with those patients. So the way our service is set up is that everything is run through the acute GPs. So the acute GP service, this seems to be the answer to a lot of things in our trust at the moment, but the virtual wards and the urgent community response clinical responsibility sits with that one group of people. So that's actually made it easier for us. So we've got an acute GP who sits on our working group, and what happens is that they're contacted to say, are you happy for us to do the point of care test? They agree with it, and then they will interpret the results once that test result is ready. And for them, what's happening at the moment is they're getting a lot of those calls about just from the lab bloods, but out of hours. So they're finding it really challenging. So for them, it's actually been beneficial because they know that if a point of care test is going to be done, they decide at an MDT for a virtual ward patient in the morning that a test is going to be done. That will be done during the day, and the result will come back during the day. What happens at the moment, or before point of care testing was introduced, is that the bloods would be taken, they'd get to the lab in the evening, the abnormality would then be phoned through at 8 o'clock at night, and they'd have to deal with it then. So they were probably already making those decisions on those patients, but just not in as timely a way.
Thank you. And we've got another question here. What key element do you think makes an effective virtual ward rather than just a functioning one?
Yeah, so I think it is having hospital level care available at home, and one of those diagnostics is going to be one of those facilitators, and all the technology enabled care like saturation monitoring, etc. I think one of the big things that we're hoping that point of care is going to facilitate from our perspective is to be able to increase the acuity of the patients on the virtual ward. I think there's some virtual wards are a little bit risk averse because it's a new thing, and if you haven't got things like point of care testing or tests available at the time, you end up putting a lower acuity type patient on that ward. So then the effectiveness would increase if you have access to things like those rapid diagnostics, so that clinical decisions can be made more quickly to admit or keep that patient at home, rather than saying, right, I'm going to keep that patient in just in case because I need that monitoring available persistently. So I think it is getting that full transition of that hospital care in that environment, which isn't an easy thing to do.
Mm-hmm. And we've got a couple of comments actually in the chat box for you. I think people just joining in the in what you've been talking about. So talking about like the future of point of care testing will be changed and how the QC will be monitored for point of care testing at home. So I don't know if you want to talk a little bit about that.
Yeah, go on. Sorry, can you say that again?
Apologies. So kind of looking into, I suppose, the future of point of care testing and how it's going to change and how the QC will be monitored for point of care testing at home.
Yeah, so the QC will be monitored by the point of care team. So what's happening is we know what day that the IQC is being done in the community. So it's being done weekly at the moment. So we know on a Tuesday the IQC is being done. We're able to check those results then back in the laboratory to check if they're in control and if we're happy with the performance. So that's the route that we're going down with a lot of our point of care tests, is that we are going to run that model essentially.
And I've got another.
Yeah, I mean, IQC sometimes isn't well, I've just seen a question in the box about the size of the point of care team, and a lot of the resource fits into that. So we're lucky where we are. We have a relatively large point of care team. So we've got biomedical scientists in our team. We've got associate practitioners. So we've got Band 4 associate practitioners, and then we've also got Band 3s. So we've got 12 in our team at the moment. So there's a lot of resource compared to other trusts. That's new. So we've been supported because they accepted that we want to roll out community services in virtual wards, etc. And to be able to govern and monitor all of these tests appropriately, you're going to need a team in place. And in terms of IQC, I think a lot of hospitals probably don't monitor it. They're just based on the lockout functionality that the devices have. So they'll run an IQC and it passes, and if it fails, the device will lock. So that's where there's an additional layer of security from that perspective. But yeah, we're lucky that we've got a big team here to be able to undertake those governance elements.
And also got another question for you of, did you refer to other hospital streams? Where did you start?
Other hospital work streams. What context was that? Sorry.
So it just says about other hospitals' work streams. So I suppose collaborating maybe.
Is this getting together the working group? Is that in terms of? Yeah, because in terms of the working group, the project manager brought together everybody that we needed to bring together into the working group from their contacts, because they're working very closely with virtual wards and urgent community response. Yeah, so that's where we're sat at the moment. And then we've included people like SWAST so that they can see how the point of care testing goes, and it's whether in the future we might develop other services or expand point of care testing into other acute services within the hospital. But this virtual ward project is the first step of that, because we need to prove the benefit first.
Oh, thank you. We've got more of a comment from someone saying, thank you so much, proud of your knowledge and technical experience.
Oh, thank you. It's been a learning curve.
So I've got another comment from Tony Cambridge, who said, at my last event, the BIVDA panelists spoke about the need for community-based scientific officers. Do you think hospital-based scientists, laboratorians, point-of-care testing staff should be working more in community settings, GPs, pharmacies, at-home care to guide the direction?
Yes, definitely. And I think that's what we're looking at now with the expansion of the point of care team and then taking on further services in the community, is that the point of care team will go out and visit those sites to support. Now, I think there's a difference between people actually going out to run the tests themselves versus looking after the governance elements. I think it's very challenging to have people physically permanently in the community, but I would see it as being supported from that local point of care service. And what you would have is the point of care team going out to visit, scheduled or unscheduled potentially. So we've had situations with our urgent treatment centre where something's gone wrong or something's needed to happen on that day, or IQC or EQA needs to be run, and they've gone out and done that. So we would probably be located centrally, but have the ability to go out and support those services in a wider capacity.